think SERENA-6 really challenges our traditional paradigm of lines of therapy and how we use our agents. You know, historically, we give a drug, we wait until we have definitive evidence of progression, and then we move on to the next drug. And this is changing that, and changing that moment that hinges on like the moment to change the drug. And you know, on the one hand, as we've talked about scientifically, this makes a lot of sense. We're hitting the target, we're going after what's driving resistance. But on the other hand, are we really going to make a big difference in the long run? And this is why we need more maturity from the study, the PFS2, the overall survival. We need to see that this big benefit up front is going to translate into benefit that continues, as opposed to just changing what's available for the patient later on. And you know, I think as well, the challenge is, and you sort of alluded to this, what line of therapy is this? Is this first line? Is this second line? Is it 1.5 line? And that also challenges our traditional paradigm of how we think about lines of therapy and how we think about sequencing. You know, I think in general, we always want to start with our best agent. We don't hold a good agent back, you know, like for a rainy day. We give our best thing up front. So that makes total sense to use our best endocrine agent when it is the right time to use it. But then it does create this sense of like, where do we go from there? So I think there's a lot more we need to learn. But, you know, I do, and I'll come back to this, I really am struck by what we've learned from our patients in SERENA-6 and how the patients report their experience and how they're feeling. Because ultimately, that's what this is all about, is taking care of people and helping them do their best. And I do think we get that signal out of SERENA-6 that this is helping optimize the patient experience and how they're living with breast cancer.
No, I totally agree, and I think we have strong primary endpoint data. I think we have extremely strong quality of life and patient-reported outcomes data, and I think we have to take some of these questions or concerns about limitations in the study design and put them into that context. One of the things that often comes up is this idea, two things, about the fact that more than half the patients had the ESR1 at the outset, and in my opinion, as we were talking about, I think that actually shows that the benefit is underestimated, and that if we followed earlier testing, we would actually intervene earlier. The second is the crossover and the fact that many of the folks in the control arm maybe didn't have access to an oral SERD, and even if they did, it was then given as a single agent, not as a doublet.